So we're going to be looking at some of the other conditions. Sometimes these come after MIs, and sometimes they just come after prolonged periods of patients having advanced disease in their hearts and aren't able to fix them medically or to control them medically. So some of these patients become candidates for coronary artery surgery. And so the CABG is the coronary artery bypass graft, and we call that CABG sometimes. And what we're looking at is reperfusing the myocardium. Makes sense, doesn't it? And there's several procedures. Not everybody's going to be candidates to have bypass grafts of any type. Some people are just not candidates for surgery, so this will depend. And we'll be talking later on, next week and the week after, about some clients that will be candidates and some that will be candidates for heart transplant as well. Just scratching the surface, guys. The mid-CABG is a minimally invasive direct coronary bypass, artery bypass graft, mid-CABG, and that's one of the alternatives. And I think I've got a slide in here that kind of gives a little bit of the differences. Okay. This is some of the usual places. You know, you'll hear people say, well, I had 4 stents, or I had this, or I had that, or I had 5 grafts put in, or 4, or whatever. You can put in numerous grafts, and these are some of the common places that these grafts are put in, all with the idea of getting oxygen and nourishment to the cardiac tissue. Okay. So looking at the CABG, they'll take some grafts and put them in below the areas of blockage, again, to give nourishment and all to the heart. Any number can be done, depends on where the blockages are and the extent of them. So vessels are usually taken from the saphenous vein, and on the mid-CABG, they take that from the internal mammary artery. Pre-op, certainly getting the patient and the families ready for surgery is going to be a big deal. What to watch for. Some of their meds might have to be discontinued, like diuretics and anticoagulants, certainly for 1 to 2 days. They will want their electrolytes and all to be up to snuff, because that's going to be a major concern, is keeping those intact. And we don't have a big area of difference for that, so we want their electrolytes to be really spot on. Usually they'll give them showers, or have them take showers with antimicrobial soap. They will shave them from neck to groin. And now in the olden days, we would use those old safety kind of razors, that really nicked up the skin, and we found that we get a lot of infections that way. So now they use the clippers, the electric shave, and they don't do so sharp. But the antimicrobial soap and all is really a big deal too. Make sure the patient understands, and the family, immediately after surgery, they'll have a vent and probably be pretty sedated. Chest tubes, NG tubes, Foley, art lines, Swan lines, Pacer lines. They're going to have all sorts of things. They may have up to 4 chest tubes, 2 on their chest, and they may have the mediastinum chest tubes in. So they're going to be wired up for everything but sound. Okay. So some of the indications, and you can look in Chapter 40 on that. And this just gives you a quick down and dirty of some of the indications. Read over those. I don't have to read those to you. Now they are doing some of the newer approaches off pump so that they don't put them on the coronary artery bypass machine. And I believe the mid-CABG is one of those. But it just depends on a whole lot of different things, and we aren't going to be the ones doing the depending, so we just go with whatever the surgeons do, and we'll see these patients as they come out. Off pump, CABG, shorter hospital stay, decrease in infection rates, and mortality risk is lowered, and cost is lowered. So you think we're going to be seeing that more? Yeah, I would think so, depending on if the patient can tolerate it and all. I still do the thoracotomy and sternotomy, still perform, so that's still a big deal, you're kind of cut from stem to stern. The minimally invasive, the mid-CABG, they also do a left thoracotomy, and the bypass machine is not required, so that's a good point. But they also have more pain than the traditional CABG. With the traditional CABG, they have the saphenous veins are involved. That's where they get their grafts from. And interestingly, the patient's biggest complaints of pain are usually their legs, or their leg from where that came. They stay in CCU, and these clients stay on not even hardly overnight, and then they're busted out in 3 or 4 days. So, preoperatively, we're going to watch their medications, make sure they aren't getting diuretics and that sort of thing, get their electrolytes great. They may put them on antibiotics. The patient should be well aware of what all is going to be happening, and the family as well. And try to allay any fears. Now, that doesn't mean we go, oh, everything's going to be great and you're going to do fine. Those are pretty scary words for us to promise. Very close monitoring after surgery. We're looking for hypokalemia in particular. They may be on nipride to keep their blood pressure. And, we always fuss and complain and want people's blood pressure to be low. Well, this is a time when we don't want it to get too low. Because if it's too low, new grafts may collapse. So we want to keep it a little bit almost high. And their lab work, really watching that potassium. We don't want them to have dysrhythmias, so we want that to stay, it's supposed to be 3.5 to 5.5. We want it to be around 4 or 5. We want to really hold to that. If it starts dwindling down a little bit, drifting down, we're going to probably go ahead and, in this post-op CVICU kind of area, we're going to give them some potassium because we don't want it to get low. They can't tolerate it being low. And the blood pressure, we'll want it to stay kind of a normal high. Okay? If they don't have any complications after bypass surgery, they're going to be gone home within 4 or 5 days of operation. Isn't that wonderful? So, but now if you've got somebody that has the cardiac tamponade occurs and things like that, obviously we're going to push that discharge date on out. Okay? Alright, so on the surgical unit, they may be on the vent for a few hours, but by the day after surgery, they're usually, barring any complications, off the vent, up in a chair. Even sometimes the evening of surgery, they're up on the side of the bed. There's not any of this laying around and you don't move for a week or two like in the olden days. Now we know getting them up and moving them is the best thing. Okay, so we will have a mediastinal and a pericardial tubes in probably to water seal drainage. And we want to make sure that all those chest tubes together don't go over 200 mLs of output an hour. So I've got here 100 to 150, and I can't remember if Iggy says 150 or 200, but that's the total of all those tubes. So if they've got 3 or 4 tubes, all of them together, we want to know if it's over 150 mLs an hour. because that's a lot, and it's mostly kind of bloody stuff, so it's not like it's just, a little water or something. So we want to know that, because those should gradually taper off. And if we see that, hey, they had the first 2 hours, they had 150 total each hour, and now all of a sudden we're having nothing. Like I said, these should gradually taper off. So we should have maybe 150, and then maybe the next hour 100, and then the next few hours we might have 75 an hour, and by a day or two we should be kind of dwindling on down. But if we get that dwindling too quick, they may be getting a pocket, they may have a hematoma forming or something. So we want to make sure these stay open to drain this fluid out so we can keep our eyes on it. But they're going to be hooked up to everything. Pacemaker. The reason they have a pacemaker in there is so that post-op they can help to control heart rates, and which in particular are slow heart rates. Now they could do what we call overdrive pacing, but generally it's slow heart rates that they may get post-op, and so that they can act like a pacemaker and bump their heart rate up. But these only stay in a couple of days, and they normally can be just pulled out by the surgeon, not a problem. I will tell you, my sister-in-law had this 10, 15 years ago, and a post-op, she had a few little complications, but they were taking her pacemaker wires out, and what I'd always heard of, hardly ever happens, but you never know, you pull on them and they come apart. Well, hers did, and it scared everybody to death, and she had to rush back to surgery. They only had to open the outer layers of the fascia and all, and there it was, and they pulled it on out. They didn't have to go all the way back in, but things can happen. It can happen, so be aware of that. Okay, so when you get these patients from surgery, certainly, we're going to be monitoring their EKG, their O2 sats, ABGs. They'll have art lines, so we can get ABGs, frequently on them. Chest tubes, swan lines, labs, IV drips, dressings. I mean, it's just, it's really head to toe, looking at them all the time. So we're going to be looking, watching the best of our assessment skills, and y'all will get to use some of these in some of your in your critical care experiences. I can't wait for you to be able to do that. Okay, let's see. Ground their pacer wires. Like I said, Mr. Holloway will talk to you a little bit about pacer wires, but they won't be, these, when they come from coronary surgery, they won't be hooked up to a pacer. But they are there and available, so we want to make sure they're not just out there flopping in the wind and available to pick up any electrical impulse from equipment or anything. So we usually put a cover over them, a glove or something, tape them up so that they're not just out hanging around. Watching their fluid and electrolytes, certainly. We don't want the client to have more edema, so we will monitor their fluids and all. But potentially looking at that collapse of the grafts being an indicator that low blood pressure, so we don't want that to happen. We want to be really watching them. Also, hypertension, really high, can cause their suture lines to leak, so we want to keep it a happy medium. That's why our job is so tough. That's why we're paid the big bucks. Looking at temperature as well, we want to because they keep them pretty cool over there in the OR. But we want to rewarm them, but we want to rewarm them slowly, like less than 2 degrees an hour, because we don't want them shivering, because then that takes up more oxygen, because that sends their temperature up. But we want to discontinue warming them once they get to like 98.6. So thermal blankets and all are usually sufficient. Again, we want to keep that potassium around the 4 to 5 MEQs. and watching for those signs of tamponade. You remember what those were. Okay, and we want to also, as they progress in their journey toward discharge, we want to differentiate between sternal pain and anginal pain, because the anginal pain could mean that their grafts are failing. Sternal pain is from their surgery site, and we do want to touch on it, press on it. It shouldn't be spongy and funky feeling. And we certainly know what infection looks like. A complication of bypass surgery is low cardiac output syndrome, and it's usually early during the post-op period, and we'll see what this shows up as is low cardiac output, hypovolemia, and signs and symptoms are hypotension, oliguria, and cool extremities. And when we want to be real aware of it and rectify it pretty quick. And it's because of these shifting fluids, that third space shifting kind of thing. So we want to treat it, and they treat it with lactated ringers or colloids, packed red blood cells, and we're watching all their INO and everything. So that's a big deal for us to be on the lookout for. Another complication is the cardiac tamponade, okay? And we know all the signs and symptoms of that. Dysrhythmia is certainly what we've been talking about. Frequent PVCs, fib flutter, and tachycardia. And remember those pacing wires. Emboli, that third day, post-op day, is kind of a common day of feeling poorly and what have you. So we want to know if the patient's having weakness, dyspnea, and all. And by this time they're out on the floor generally, and they're starting to increase their walking and all. So we'll be monitoring their blood pressure to make sure, and pulse, to make sure they're not having untoward effects of the activity. So we want to let the physician know that if we have any change in their blood pressure, up or down 10 millimeters, or their pulse up or down. Fever, certainly infection. We want to know those things. Could be from the wound, could be from pneumonia, so we're always on the lookout for those things. And, hey, they could have had another MI while they were on the OR table. So that's something we always want to watch for. By this time, they're getting a lot of their tubes out, and they are starting to transfer out to a surgical unit. Certainly, they're going to be looking, vital signs, always going to be giving us the baseline, their level of consciousness, how their pulses all are. They're going to keep them on a cardiac monitor so that they can, or telemetry, so they can watch for dysrhythmias, watching their lung status, encouraging them to splint with a pillow to hug, against their chest, and cough and deep breathe, and using incentive spirometry, and also getting them up and walking. And usually they will make them be walking so many laps around the unit before they can even be considered to go home. And that's an incentive to patients to get up and get moving, and that it's okay to be moving. Okay? Again, we're looking at that sternal suture line, making sure it's stable and that they're not getting any infection or anything. Activities that drop their blood pressure 10 to 20 milligrams of mercury, and their pulse up more than 10 beats. Have to have them slow down. Getting them home. Limit pushing, pulling, and lifting and toting and all that for 6 weeks. Teach them what they need to do about their incisions and when they need to call for medical attention. The sternum usually heal in about 6 to 8 weeks, so that's a good thing. Avoid crossing their legs, all those usual things. Certainly we'll be giving them information on whatever meds they're going to be on, follow-up care, dietary restrictions, that kind of thing. What always comes up is, when can they have sex? Well, basically, the doctor will be telling them that kind of stuff. However, kind of a rule of thumb is when tolerance is to where they could walk like a block or climb 2 flights of stairs without any symptoms, then it's pretty safe to resume sex. Okay? More than you wanted to know. All right, looking at heart transplant, which is another thing. Who needs a new heart? Some of us that are heartless, is my guess. If you remember from your days talking about renal and renal transplants, they do the same testing for these organs, for the heart organs. They have to have the ABO compatibility and all that sort of stuff. So all that's the very same. One of the differences is that a heart is only good for like 6 hours after it's procured. So, and what they'll do is they'll remove the patient's heart and leave part of the heart in there. They put them on the bypass, obviously, or they'd be doing nothing. And then they put this new heart in there. And I think I've got a little bit of a picture. And that's kind of the older version of what they would do. They have some newer things, but I don't happen to have a picture of that. So they cut away their heart and leave this as a base, the old heart as a base. And then they take the new heart and sew it in on top of it. See, sew in here, and then they flip this over and sew there. So, but they have some newer ways. But what this leaves you with sometimes is a double P wave. But often one of them will be kind of buried in the EKG, so you might not see it. And usually the transplanted heart is the nerves have been cut away, and also these patients generally do not complain of angina. So what we're interested in are what are the signs and symptoms that the patient is rejecting the heart. That's kind of something that we want to know about. And that's going to be hypotension, dysrhythmias, weakness, fatigue, and dizziness. Those are pretty standard things. And to know that, we're going to do myocardial or endomyocardial biopsies at regularly scheduled intervals, and that varies from institution to institution. So, and then if they are suspecting rejection, they will go on in and do one as well. So these patients will look for that for a long time. And there's a lot of different patients that are a surgical choice for a transplant, like patients that have dilated cardiomyopathy, and I think we'll discuss that next week. Early on, they'll use isoproterenol or isoprel drips to support heart rate and maintain urinary output on these folks, and they'll give them some other drugs and things too. I think on page 770 there's a chart, 37-10, and it assesses the clinical manifestations of heart transplant rejection, so you might want to breeze over that. Some of these heart transplant patients may also need permanent pacemakers to keep up with individuals' needs, because a transplanted heart usually just kind of has a set heart rate around 100, so it won't be able to accommodate patients' needs if they're runners or this or that, or if they get chased by a bear or something. No, I'm just kidding. So they may need a permanent pacemaker as well. But you can kind of look over that about the heart transplant rejection. I think it's kind of interesting. Let's see. Oh, and one, I wanted to make sure to drive this home. Remember how the patients that had kidney transplant had to be on immunosuppressive therapy forever, like the Neoral cyclosporine? Well, hello. Same thing happens with these as the same thing for the kidney transplant goes for the heart transplant as well. So this is not new information. So that's something to think about. And also the prednisones and all. And they sometimes have to adjust the rates of those, just like they did in the kidney patients. Okay? intra-aortic balloon pump, what these do, and you can read in your book. I want to say it's page 844. I'm not sure. But it's invasive intervention, and it improves myocardial perfusion while the patient's having an MI, or kind of buys them some time. It reduces the preload and the afterload, and it can help with the left ventricular ejection fraction. These are inserted percutaneously and through a cut down, and then they're inflated during diastole, and it helps the diastolic pressure as well, and improves coronary perfusion because it increases the blood flow to those arteries. And there's some other devices as well. Let's see. Circulatory assist. This is like kind of not the artificial heart, but a ventricular assist device. Buys time until they can get the new heart or whatever. So they have some external ones that were really big machines set by the bed. Now they have these smaller compact things that certainly it goes inside, and it's an external little pack they carry, but very much compact, more than they were even 5 or 10 years ago. And this is the one, you remember the Vice President, Dick Cheney, had one of these, I believe. So you can look up in Iggy, might have a little bit about it. You can go online and look up a little bit about it. And that's pretty much what we're going to talk about. We'll continue up with just a little bit of advanced cardiac life support on part 3. Thanks so much.